Okay. Um, so thank you very much for the opportunity to present and share some of the lessons that we've learned in Australia from COVID-19. So I'm infectious diseases physician. I think I'm the equivalent of Omar in Argentina. I'm the president of our Australasian Society of Infectious Diseases, which is for infectious diseases physicians, and also sitting on our Australian Health Protection Principal Committee, and I'll explain a bit more about that and some of the other roles in a moment. So Australia is actually about as long as Argentina, and but 3 times as big, with a population about half that of Argentina. And obviously, when we think about COVID-19, we have a number of advantages. We are basically a very large island with no borders, land borders with other countries. Although we have quite a relatively small population, it is quite highly urbanized. So most people live in cities, and very few people live outside of the major cities. We are a high-income country and have a universal healthcare system, a public healthcare system, with some private hospitals as well. Our reference laboratories are relatively strong, although there are some issues with having multiple diagnostic laboratories. And it'd be fair to say we have a relatively strong public health system, particularly in Hunter, New England, where my colleague Craig Dalton is from, but it does vary around the country. We also had quite a lot of early warning that we were going to have problems. Our first case of COVID-19 was on January the 25th, and we had a small number of cases in travellers towards late January and early February. We do have some disadvantages, though. Two of our cities are in the top 20 destinations for Chinese travellers, as Melbourne and Sydney. Australia is not really a single country. It has 8 different governments. Some of the jurisdictions, Tasmania is very small, Victoria and New South Wales are very large, and they have different capacities to cope with health crises. We have quite a diverse population with many languages and cultures, so things cannot always be messaged in English or in a single language, and we need to communicate in many languages. There's always been an awareness that we have many remote Aboriginal communities, and these are places that are very many kilometres from major centres, and Aboriginal and Torres Strait Islanders, our Indigenous communities, have a high rate of chronic disease and are very vulnerable to infections. We have, like everywhere else in the world, an increasingly casualised workforce, which can make it difficult for example, leave arrangements. And our diagnostic laboratories, there's many private laboratories, and they're somewhat fragmented. It's hard to communicate with some of these laboratories. So I mentioned before about our system of government being relatively complicated, and this is reflected in some of the arrangements for public health. So at the moment we have what's called a national cabinet, and the national cabinet is comprised of the Prime Minister of Australia, and then each of the state and territory premiers, which are, I think, the equivalent of governors in Argentina. And so they meet every week or 2 weeks to make decisions about national policy. And then advising them is what's called the Australian Health Protection Principal Committee, which is made of the chief medical officer of the country, and then all the chief health officers of each state and territory. So this is mostly public health officials, bureaucrats, and there's a number of people like myself and mathematical modelers and infectious diseases physicians who are invited experts to this. So this sounds a little bit like your presidential advisory committee. And then below them are a number of different committees. One of these is what's called the Communicable Diseases Network of Australia, which is all the heads of the communicable disease branches. We don't have a Centre for Disease Control, and so this is our arrangement, is to have lots of committees, and it's very much a network-based issue. Very early on, we had what's called a national incident response called, and a national COVID-19 response plan was rapidly adapted from our influenza response plan. This is our epidemic curve in Australia, and across the bottom you can see some of the measures that were taken. So you can see put on a travel ban for passengers coming from China, and then as further countries had epidemics, the borders were closed to those countries, and then by mid-March completely closed. And then you can see some of the other measures that were taken towards early to mid-March. At that time, a lot of the cases that were coming in were actually travellers rather than local transmission. But I think there was sort of a lot of enthusiasm for closing a lot of things in Australia, and you can see some of those things there. So at one point, gatherings were only limited to 2 people. You could only meet one other person that was not in your household. I think it's quite interesting to see that the settings that we've had major transmission events in are really the same settings that almost every other country has seemed to have in the world. So obviously cruise ships, there were many Australians on the Diamond Princess, but we had another cruise ship that docked in New South Wales and had many cases there. We haven't had many outbreaks in schools or childcare centres, but there was one notable one in New South Wales. Nursing homes or aged care residential facilities, there's been a number of outbreaks in those. Meatworks, I think, require a lot of people to work very closely to each other, and we've had an outbreak of that. And then more recently, we've had some problems with quarantine facilities where overseas people are being diagnosed with cases and they've continued to transmit on to some of the security guards in those areas. And then we've had a number of quite large outbreaks that have occurred at family occasions, particularly in Victoria and us also. So after the cases started to settle down, the Prime Minister announced that these were the conditions that we needed to have before we could reopen again. And this was announced on the 16th of April, and we've basically been spending the last couple of months working on all of these. And these were the conditions were to have a surveillance plan so that we had good situational awareness of where we were and what we needed to be doing, and with a lot of mathematical modelling and analysis behind that. We had to have more public health capacity, and there was a COVID-safe app that was launched, which hasn't been that successful. And then we had to have an assurance that our health system could cope, the hospitals and primary care could cope with what would come, and that included supply lines for personal protective equipment and pathology and ventilators and so on. So in the last couple of weeks, most states have not had many cases. So a lot of these cases in other states other than Victoria have actually been in travellers rather than in the community. But you can see in blue, we've had this ongoing trickle of cases in Victoria, and over the last couple of days, actually, that has increased to about sort of 20 to 30 cases a day. And these are arising in certain parts of the city. So these are being called hotspots in these 6 areas. The grey is the city of Melbourne, and then the orange are these hotspots. So they're quite large areas, and they're sort of on the outskirts of the city. And so the response to this has been to deploy mobile clinics. The army actually have been sent in, and a lot of hospital workers have been sent out to some of these areas to go knock on doors and make sure that people get tested if they're unwell. There have been clinics that have been set up in shopping centres so that people can easily get tested. And some of these outbreaks have occurred in ethnic communities, in many communities that where English is not their first language, and there is a lot of engagement with some of these community leaders to try and make sure that the messages get through. The Premier has also announced what's called pandemic leave for some workers who cannot take time off work. They don't have any sick leave from their work. They can get a payment from the government to make sure that if they quarantine, they can still support their families. These outbreaks have been relatively complicated. I mentioned the quarantine hotels. Some of them have involved quite large households. So there are 20 or 15 or 20 people in a household, and at family gatherings. And then again, involving some of these smaller communities. Some of the ongoing issues that's been discussed in Australia are we actually aiming just to suppress the virus, or are we trying to eliminate it from the country, bearing in mind that there is a risk of introduction. We still have internal border controls, so that between some states, such as between New South Wales and Queensland, and I think South Australia and Western Australia, there is still, you cannot travel across the border, or you have to quarantine if you do travel across. And then how long can we continue to quarantine incoming travellers for? Obviously, it's a big undertaking to do that. I think the point of that looking for marginalised populations, I think we have, Singapore had their issues with foreign worker dormitories, and I think we have now had these issues with our marginalised populations as well. I think it'd be fair to say that public health capacity is still a little bit limited. It's one thing to have lots of contact traces, but particularly in complex outbreaks involving businesses or hospitals or nursing homes, this is not something that that can be left to routine follow-up. So in Victoria, there was about 60 of the public health officers, and then they brought on a whole lot of nurses. Some of them were nurses that would normally do elective surgery. Some of them were people that happened to be in Australia on holiday. They were nurses from Ireland and England, and that otherwise would be backpackers in the country. And they were very helpful at some of the routine follow-up. But when it got to very complicated situations that require judgment, it becomes somewhat more difficult. And then I think the other issues that most countries have had, personal protective equipment supply is still somewhat limited in Australia, even despite not having so many cases. And then obviously the economic impact and the political considerations around that as well. So in thinking of sort of what can be done, I think this is the public health toolbox. So things that the messaging that we put out to people about physical distancing and personal hygiene and so on. There's the actions that rely on knowing that a person is a case. So this is the sort of traditional test, trace, and isolate, and then more complex outbreak management, and then closures of school or work. There's the actions that are reliant on regulating behaviour somehow, and obviously this does require perhaps some enforcement, so stay-at-home orders and limits on gathering and capacity, and obviously it's very hard to police some of these things. And then obviously the border measures. And I think Craig has discussed contact tracing. So in Victoria, which is a state of 6.6 million people, there's probably about 60 public health officers normally, and then about 1,000 contact tracers overall. And then I think there is a consciousness to try and separate out some of the tasks. That the first part of it is to investigate the case and find out who their contacts are. The second task is to find those contacts and to make sure that they're in quarantine. And actually, even after you put them in quarantine, there is a need for ongoing support to make sure that their pets are looked after and they have food, and they can stay in quarantine to keep them there. I think the response to increasing cases, at least in Australia, is to try and sort of take assessment of what is the current situation, not just the numbers of people that are being diagnosed, but what is the capacity of the health system and of the public health system to respond to that, and to try and get an idea of what is the behaviour of the population, what are people doing. And so we're looking at data such as Google Analytics and smartphone movements, just from Google and Apple, to see what sort of people are moving. We're doing surveys to try and ask them, how have you returned to what you normally do, or are you still able to stay away from other people? Then the other marker, I think we use this quite early on as well, is to ask ourselves, is there enough testing going on? So some of the markers for this are the case fatality. Obviously, that's very heavily influenced by age, but that gives an idea of how many cases might be missed. And also the proportion positive. If that spikes up above 5%, then maybe there's not quite enough testing and there may be missed cases again. And then it's not just the numbers of testing, but also who is being tested, and are there populations that are being missed? And obviously we have missed them in Australia as well. And then if there are people that are not tested, what are the things that will allow them to get tested, or what are the barriers to stop them getting tested, and if those can be addressed. And then in terms of keeping an eye on the contact tracing system, how many contacts are there for each case as a marker of social distancing and so on. What is the delay in completing the contact tracing? How long does it take to get to the end of that? And then how many of the contacts that are nominated are actually can be located? I think this has been a question that we have asked about: when when do you need to close, and when might you need to open? And I think this was early in our outbreak. The decision to close was the realization that just contact tracing or just public health probably couldn't control the outbreak by itself. So where the number of cases exceeds the capacity of health services or public health to treat them or to prevent them is probably an indication that a lockdown is required. And noting that there is a delay in response. So even this recent number of cases in Victoria, we don't expect that all the things that we do now will probably take effect for probably another couple of weeks. And in terms of opening, I think the idea is to try and control the virus by less disruptive measures, and then having all these indicators in place to know when do you have capacity to do this is important. In terms of different epidemiologies, this is obviously an issue that we're facing in Australia with active cases in Victoria, but not active cases elsewhere in Australia. And I think there is this argument in Australia that some people, particularly people that live close to the border, will say, well, why can't I go over there? And particularly with internal land borders, it's very difficult to enforce to stop movement across borders. So I think at a jurisdictional level, at a state and territory level, the argument is made that if we don't have any cases and they have cases, we can open up further because we're not letting in their infection from over there. When we get to sub-jurisdictional borders, so suburbs of Melbourne, it is almost impossible to enforce. You can't lock down a particular part of a city because there are just so many ways in and out of them. And so that probably isn't feasible, and we're relying on people, recommendations and messaging to these areas to try and reduce the traffic. In terms of, I think this argument is made that there is the need to protect public health is somehow at odds with the impact on the economy, but I think this ignores the fact that uncontrolled infection has probably a large economic impact as well. I'm sure the United States and Brazil will have a large economic impact, even despite being relatively open. But I think we do need to recognise that public health measures, particularly those that impact on the economy and on the jobs, have a large risk of making inequality worse. It's easy for office workers to work from home, but it's not so easy for many other groups to work from home. And this is very much a disease that will find the vulnerable populations, as we're finding out in Victoria at the moment. I was also thinking through just what were the sort of, what are the lowest cost interventions that can be done, and I think this is one way of perhaps mitigating some of the impacts of COVID, while trying to allow things to activities to happen. So obviously messaging is easy and cheap, but what are the things that can move outside? So can restaurants be outside? Can all the other activities be outside as much as possible to reduce that risk? And then this argument, particularly at very intense transmission, having a universal mask or face shield policy, particularly where social distancing may not be possible, may also be another thing that can be done. So in summary, I think Australia and many other countries have shown that control is possible. This is a disease of super spreading events, particularly in households. So this time, space, people, place, I'm not sure what the equivalent in Spanish would be, is this, sort of define the settings where transmission can occur. The public health toolbox isn't very large, but public communication, contact tracing, things that require regulation and border controls are part of that toolbox. But it is very important to have awareness of where the situation is and to keep an eye on case counts and what's changing. And then there is this need for, in Australia, we call it the Pandemic Intelligence Plan. So this is the surveillance plan, but it's more than just disease surveillance, what we really usually think of surveillance, but surveillance of capacity of the health system and public health, and things like public attitudes and behaviour. So thank you very much for the opportunity to talk, and happy to take any questions.